Welcome back to It's Your Case, presented by VetCT.com. I'm Heather, your radiologist on demand for this week. This week's example is an 8-year-old boxer with thrombocytopenia. We are screening this patient for pulmonary metastasis. Once you've reviewed the radiographs, then you're ready to watch this video. Screening for metastasis is a big part of my day as a radiologist. It's really a special kind of interpretation. It involves careful assessment of each portion of the lung on all views. I do this on every single case. It's somewhat of a separate decision for me than looking at the lung pattern. When I'm looking at lung patterns, I often have more than one radiograph that I'm looking at where I go back and forth with my eyes between the lateral view and the VD view. When I'm looking for pulmonary metastasis, I only focus on one part of the lung on one view at a time. And I literally comb through it in a kind of systematic way. I generally start dorsally and move ventrally, as I'm showing you here. When I'm looking at a case like this, where we're screening for metastasis sort of as part of our routine medical database, but we don't have a known primary neoplasm, I go through that process of combing the lungs on all views with the view really zoomed in. I go through that process one time. When I have a patient where we have a known primary neoplasm and we're highly suspicious of metastasis, such as, for example, say a dog with osteosarcoma, and perhaps whether or not the dog has metastasis could affect the family's decision around treatment, I tend to go through this process twice in those dogs to make myself extra confident. So, what does that process look like? As I said, I really like to kind of zoom in for this. So it's definitely a situation where I get so kind of up in looking at the lungs close up that I definitely have sort of a loss of the forest for the trees. So I would say if I'm trying to decide about lung patterns, like I kind of alluded to at the beginning, that's a bit of a separate process for me where I need to see much more of the radiograph at once. But I basically just kind of go through here and I look to see whether anything looks sort of kind of nodular, rounded to me as I go through. I want to use some examples that are in this part of the lung here to talk about what do I do when I'm looking around and all of a sudden I stumble across something that looks nodular. And I'm pointing to an example, for example, right here. I then kind of bust into a subroutine in my brain where I think about a whole bunch of criteria. My approach to this is either you could phrase it as I'm trying to prove that this is a metastatic nodule, or I'm trying to prove that it isn't a metastatic nodule. It doesn't really matter philosophically which of that kind of approach you take. What I think matters is that we apply the criteria consistently. So I've been combing through the lung and I find this nodule here. Here are the criteria that I go to next. Excuse me. I first look at the opacity of the structure. When I see this structure here, relative to other structures on the radiograph, and I'm kind of zooming out to give us a vibe on this, this is very opaque for the size that it is, okay? I realize that it's a super small structure, but its opacity is almost similar to the liver. So when something this small is this opaque, it starts to make me think, hey, this is not just a straightforward soft tissue opacity, this is more opaque than that. For example, mineral opacity. The next thing I start to think about is size. So in my world, with my digital tools, I can usually get an idea of size by simply applying the measurement tool. When I apply the measurement tool here, you can see I'm getting less than 2 millimeters as the overall size of this structure. As a rule of thumb, if a soft tissue nodule in the lung is real, it would generally need to be 4 to 5 millimeters in order to be able to be seen on the radiograph. Why is that? Well, a soft tissue nodule is not going to attenuate very much of the X-ray beam when it's really small. If it doesn't attenuate very much of the X-ray beam, then it hasn't altered the diagnostic information that results on the film that you make. So a cut point of sort of 4 to 5 millimeters is the minimum that we generally accept for the size of a soft tissue nodule. So regarding this one that I've indicated here with the pink arrow, I'm now at the point where I'm saying, hey, I think it's a mineral opacity. I also think that it's too small to be made of soft tissue, so that helps me to know that, yeah, it's made of mineral. The next thing is margination. This structure is, I would call it fairly well margined, but I wouldn't call this structure perfectly round. I would actually say that this structure is maybe ever so slightly oval. The last thing I look at is alignment. So my radiographic finding of alignment when it comes to this is I'm especially interested in whether something lines up with pulmonary blood vessels. So I would conclude for this particular item here that it's very consistent with incidental osteoma. The probably most accurate term for osteoma is ossifying pulmonary metaplasia. And this kind of comes from what is accepted by pathologists as a process of metaplasia, whereas osteoma would imply a different underlying sort of pathologic process. I often put in my report ossifying pulmonary metaplasia bracket osteoma because I'm familiar that osteoma is the term that most people are comfortable with, and it's a little bit more straightforward. So for me, based on my criteria of opacity, size, margination, and alignment, these where I put the pink arrows are all very consistent with incidental osteomas. While we've been talking, you may have noticed there's some other areas up here that also have the appearance of sort of nodules. I'm going to put a circle on one of them here. So let's look at this one next. So this one is a little bit different to me when I think about these criteria. So first of all, I will say that when it comes to opacity, we could also say that this structure is quite small, but yet it's very opaque. In this case, I don't think it's a mineral opacity, and I'm going to come back to why in a second. My next thing is size. So we can clearly see that this structure is going to be kind of similar to this one or a bit bigger, so we can say it's 2 to 3 millimeters, but it's definitely not as large as a structure would need to be to show up as a pulmonary nodule. The next thing is margination and alignment. So this one is maybe not very well margined, but alignment is where I really want to put a focus here. When I trace the pulmonary blood vessel, I'm going to use this line to show you where I see the pulmonary blood vessel, and then I'm going to move it out of the way. So when I trace that pulmonary blood vessel here, this appearance of a nodule lines up perfectly with that vessel. I'm now going to move the circle so we can really look. So do you see how this is actually a branch of that pulmonary blood vessel coming out? That explains why it's round. But why is it so opaque? Why is it similar in opacity to my osteoma? Because if it's a blood vessel, it should be made of soft tissue or fluid opacity. Well, in fact, this structure, because it's representing a column of blood, there's quite a bit of blood within it, but we're seeing it end on. So it's more opaque because it's a summation of a large amount of blood that we're seeing end on. Other examples of areas where I would conclude that we're dealing with end on pulmonary blood vessels, again, mostly based on how they align with the adjacent blood vessels, would be this kind of set of pseudonodules here. Okay, let's go to the VD view. On the VD view, many of you may have noted that there's this super interesting structure up here in the left cranial lung. I'm going to zoom in on it because, as I said, when I'm looking at lung patterns, I'm definitely looking at the broader picture, but when I'm looking for nodules and screening for metastasis, I like to get right up in it. So here we are. For the next layer of our assessment, I want to keep it really kind of simple. When I look at this structure, I'm seeing a radiolucent structure that looks like gas. I'm seeing that it has a wall, and I'm seeing that next to it, there's a rounded soft tissue structure that when I look at this soft tissue structure, it aligns with this soft tissue tube. So what do I think that we're looking at here? This is in fact an end-on bronchus, which we don't catch very often. And next to it is the corresponding vessel, which is more opaque where it's seen end on and less opaque when it's seen in longitudinal. So this is definitely a mimic and is not concerning for metastasis. I'm going to go back to our other view to show you there was one little thing that I was worried about in this case, and I want to kind of show you what I do when that happens. So we spend a lot of time here in this part of the lung field, but I have been ignoring this little region right here. So this structure, and I'll get rid of the rest of this stuff so it's not so busy for us. So this structure, again, when I think about what opacities are represented here, it kind of has a somewhat similar vibe to the one we just looked at on the VD view. If I really look carefully in the center, I see a tiny radiolucent center, and around it, I see soft tissue opacity, and maybe some of that is a vessel adjacent to a bronchus. How would I handle this? In this case, we really don't have any other evidence of metastasis. We also don't have any knowledge of a primary neoplasm. So I would probably describe it and conclude that it's a summation and that it's not a metastatic nodule. My process may be slightly different from that. If this were a patient with no neoplasia, I might be more aggressive or more aggressive in what I recommend or more conservative in how I interpret it. So, what do we do when we're really not sure? I think it's always good to have kind of a toolkit to go to when we're not sure about our next steps. I think when we're facing a questionable pulmonary nodule, there's a few options that we have. One, this is going to sound simple, but as a radiologist, repeat the view. And it doesn't even have to necessarily be a follow-up view. You could just repeat that same lateral and just see whether that kind of changed anything. So here's the first right lateral view that was made for this patient, which is the one that I posted on social media. A repeat view was also made. Can you see that on that repeat view, that region is really not manifesting the same way? We don't see anything as concerning for a nodule. We maybe see a whiff of that kind of same bronchus in that area. So for me, repeating the view at the same time can be a really helpful technique to say, you know what, that was just a fortuitous, or depending on how you look at it, an ill fortuitous summation. So repeat the view. Of course, we can always repeat the view as a follow-up. So we could say, well, if this is truly metastasis, we would expect it to progress. So we could repeat the view. I usually recommend 2 to 4 weeks, and where within that window you would land with your recommendation of when to repeat would depend on how concerned you are about the patient as well as the clinical history. You can always get a second opinion from a colleague in your practice or, of course, from a teleradiologist. I think the last thing that I would mention is the gold standard, of course, would be to do a CT. And we sometimes would recommend that where the decision about whether pulmonary nodules are present or not would affect the treatment plan. So, when facing a MET check, to summarize, I comb carefully through each lung field and I zoom in when I'm doing that. That process is something that I do with my eyes completely separate from when I make my assessment about a lung pattern. I use the radiographic findings of size, opacity, margination, and alignment to help me decide where I want to kind of land on suspicious areas. If needed, I use follow-up imaging or even CT to help me make the call. So be sure to review the full report associated with this case. Join us next week for another question about pulmonary nodules. Thanks for listening, and remember, it's your case. So please post your questions and comments on social media.